say Dr. Yaszay used to work down here at Rady Children's in San Diego for a little more than a decade, and worked together actually with us quite a bit. And then recently had a great opportunity to go up to Seattle to the University of Washington, and is now vice chair of the department and runs the pediatric hospital and the whole pediatric division up there. And anyways, Burt's a phenomenal surgeon and probably even better human being. And we're so excited to have you here again today, Burt, to share with us on this topic. And thanks for making the time.
Thanks, Greg. So, you always know how to make somebody feel really good, so appreciate it. Thank you all, and really appreciate the invitation. As Greg had said, you guys have a really special group there, and really enjoyed my time working with you all. So I'm going to be talking a little bit about congenital scoliosis. It is probably, if I looked at kind of what the percentage of patients that I deal with that are deformity, it's probably, it's on the smaller side, but it ends up being probably the most complicated of the patients that I treat. So essentially it's spinal deformity secondary to a vertebral anomaly that occurred during spinal development. It's the only scoliosis that happens since birth. It doesn't mean that there are other scoliosis that can't, but this is the only one that consistently happens from the time of birth, and comes really in two forms: a failure of segmentation and a failure of formation. And I'll talk a little bit more about that. This may be the only way, really, when you talk about this diagnosis, that you really kind of delve a little bit into how is the spine formed, and a little bit about the embryology of the spine. And so the spine develops essentially from these somites, where they split up and they develop into a sclerotome and a dermamyoetome. And it's essentially, that's why you have the distribution of muscles and skin to each of the individual level of nerves. And each sclerotome then separates into two levels, essentially a loosely packed cranial level and a densely packed caudal area. And it's actually intervertebral disc that forms between the two of these levels. The annulus fibrosus forms from the migrating cells from the caudally dense layer, and then the nucleus pulposus develops from the notochord. And it's really this kind of, direct kind of development of the spine that lends itself to really what we see from a congenital standpoint. So there's a lot of fusing and separation of the sclerotomes. And so it's really two adjacent pairs of somites that really form an individual vertebral body. And essentially, ultimately will lead to what the two types of failure formation and failure of segmentation. The other thing that's important for the embryology of spine is obviously, when does the spine become cartilaginous, and then when does it ossify? So chondrification is in week 6 and 7. Ossification is really week 8 and beyond. There are 3 primary ossification centers for essentially the thoracolumbar portions of the spine, the centrum, which is the vertebral body, and then the 2 vertebral arches. The junction between the vertebral arches, the ossification center, and the body, you'll see these neurocentral joints, or neurosyncondrosis. And why this is important is that this actually closes up somewhere between year 5 and year 8. And when we're instrumenting on really small kids, that neurosyncondrosis actually kind of prevents a cancellous channel from really developing in the pedicle, kind of the junction of the pedicle vertebral body. And so it can make it a little bit more challenging to get pedicle screws in the really young kid. The other thing that's important from a spine development standpoint is that the fetal position is really all kyphosis in the spine. So the entire spine is initially kyphotic, and we don't really develop the cervical and lumbar lordosis until we start doing more upright posturing. So when the infant starts holding the head upright, that develops the cervical portion of the spine into cervical lordosis. And it's really a sitting and standing posture that really develops the lumbar lordosis that we see. So at least now getting back to congenital scoliosis, it has an incidence about 1 in 1,000. For whatever reason, some of the articles suggest that there's a little greater propensity in girls versus boys. I have no idea, no understanding of that. Unlike adolescent idiopathic scoliosis, where the progressive and surgical side is 10 to 1 from girls to boys. Causes typically are in utero exposures, so whether it's toxins, some suggestion of carbon monoxide in a mouse model, maternal diabetes, the mom taking epileptic drugs, and then there are some, a small portion of which seem to be genetically predisposed because of a familial incidence. Again, there's two types of really congenital scoliosis, and there's a failure of formation and again, a failure of segmentation, and we'll go through each of those individually. So failure of formation, there are a lot of terms in congenital scoliosis, and they're important both because they're descriptive, but they have some value in relationship to prognosis, at least in terms of deformity progression. So wedge vertebra really is, the vertebra is there completely, but it's asymmetric with typically one side being hypoplastic. It is defined as a vertebra that has two pedicles, which is different than, for example, hemivertebra, which is an absent of one pedicle or portion of the vertebral body. Now, I think what's important is, and we encounter this with families all the time, they always ask, is it an extra half a vertebra, or is it a lack of half a vertebra? And really, because of it's in conceptually, it's in the failure of formation. It's never an extra half a vertebra. It really is a missing portion of the vertebra on the side that the hemivertebra is not on. But we frequently describe it as an extra half a vertebra because our surgical technique for taking care of this is typically a removal, and it's easier to convince parents that you're removing an extra vertebra. There are some other names that are important to know, and that's whether it's segmented or not. And theoretically, every hemivertebra has two areas where it can be segmented, cranially and caudally. So segmented hemivertebra has a disc above and below, partially is fused on one side, and an unsegmented hemivertebra is fused on both sides. The reason that it's important is because really when you have an open disc, this is where you have the growth potential. So an unsegmented hemivertebra, it essentially has no ability to continue to grow, whereas a segmented hemivertebra has essentially the normal ability to grow that a vertebra has. And that's because the apophyseal ring is responsible for the vertical growth of the body and exists on each side of the vertebra. A couple other names, there's incarcerated, and that essentially means that the vertebra above and below accommodate the hemivertebra. And essentially the best way to define it is if the pedicle of the hemivertebra lines up and is continuous with the pedicles above and below. And then there's this hemimetametric shift, which is essentially hemivertebra on one side and then on the contralateral side, with the idea that it essentially off-balance each other. Most commonly, it's seen in the thoracic spine. I would love to tell you that they truly, off-balance each other, but a lot of times they do leave a patient that seems somewhat balanced. So let's look at failure of segmentation. So failure of segmentation, the most common one that we actually do see is a block vertebra, which is a complete connection between the two vertebral bodies, essentially. As you see the picture right here, no real risk of progression. Whereas a bar means that there's a portion of the hemivertebra that's fused on one side. I think a lot of us are now appreciating in the thoracic spine that fused ribs can be a form of failure of segmentation as well, because they connect really rigidly with the spine. They can also essentially be a tether on that side. The mixed deformity essentially means you have both. And these come in all kinds of forms. Sometimes they're really severe. Sometimes they're severe and progressive. Sometimes they're severe and they don't progress at all. So if we look at natural history, it's a type of anomaly, how much more the patient has to grow based on age and growth and location of the anomaly that determine the risk of deformity progression. Anomalies that are usually at the junctions between either the cervical, thoracic, or lumbosacral are typically the most clinically visible. And curve progression is associated with most rapid growth, which typically happens in the first 5 years of life, as well as in the adolescent growth period. McMaster is pretty much the study that still defines most of the work in congenital scoliosis. And in addition to kind of just defining, the different types of congenital scoliosis, it also helped us to better understand the risks of progression. So block vertebra, wedge vertebra, typically low, not very much progression. A hemivertebra, especially a fully segmented hemivertebra, has kind of a moderate risk of progression. And then if you put a contralateral bar with a hemivertebra, you can see that you basically have extra growth on one side, no growth on the other side, and that risk of progression can be quite high. Some additional risk factors for progression is if it's located in the thoracolumbar region, and then if there's presence of a rib fusion. As we look at before we get to the treatment for congenital scoliosis, there are some associated things that are important to learn about it as well. Up to 60% of patients can have some form of other abnormalities. Remember, these patients typically develop in utero from some exposure, and there are other organ systems that are developing at the time that the spine develops. And when it's a pretty severe insult, you can get either of these two syndromes of Otter or Vactorel, where essentially, in addition to the vertebral anomalies, you can get anorectal atresia, tracheoesophageal fistulas, renal anomalies, and then in the Vactorel, you get what you get in Otter, but you also get cardiac anomalies and limb defects. If we look at some of the associated anomalies, renals, about 20% of the patients can result in anywhere from having one kidney to duplicate ureters or horseshoe kidney. These are typically best evaluated by a renal ultrasound or an MRI. And so if in a newly diagnosed congenital scoliosis, I will usually order a renal ultrasound if an MRI doesn't show the kidneys. Cardiac, this is not something where I'm super comfortable in ruling these patients out. So, sorry. And so typically I'll either screen for an echo if I'm really concerned, but the reality is I'll probably have a conversation with the pediatrician. A lot of times when they have cardiac anomalies, the cardiac anomalies have been diagnosed early on birth, and so it's not usually the orthopedic surgeons that are making that diagnosis. Neurologic, up to 35% of the patients can have some associated spinal dysraphism, either diastema, tethered cord, Chiari malformation. This best evaluated by MRIs. And it's obviously important in a couple different reasons. One is some of these spinal dysraphisms can lead to further progression of the deformity. But if you're going to also do a surgical intervention, there have been some studies that show that these spinal dysraphisms can increase the risk of neurologic injury during a surgical procedure. Some of the associated musculoskeletal anomalies, again, we're all spine surgeons, but need to look at the limbs. So limb hypoplasia, DDH, clubfoot, and Springle's deformity, which is just a elevation of your shoulder, can be all associated findings. So it is important to do a history and physical. You want to know what the neurologics are of the patient. And since we're dealing with really young patients, you want to know what their motor milestones are. They're not always going to be able to, walk and do all the things that you would normally expect an older patient to do. Obviously, you should look at both the spine and the limbs, get a complete medical history, and then review of symptoms. When the patients are presenting pretty young, the spinal deformity may be the initial presentation of an underlying syndrome. So you might be making a diagnosis that has more consequences to the patient based on cardiac or renal than even their spine. As for imaging, view the entire spine. So if there's a congenital anomaly in one area, you got to make sure it's not in another. Think of it as a spine fracture. From that standpoint, anything can affect any portion of the spine. And document progression. So plain radiographs are needed just over the course of time to know whether there's any progression. And then if you see congenital anomalies in the cervical spine, consider getting flexion extension views. Other additional advanced imaging, if I'm going to get a CT scan, I'll get it with 3D reconstructions. The CT scan is important when he talks about defining the deformity. It can find additional abnormalities that are not even seen in plain radiographs up to 50% of the time. I typically don't get a CT scan unless I'm doing some preoperative planning. Because of its higher dose of radiation, especially for kids, I do not use it for monitoring. And this is more a little bit historical, but when you do get a CT scan, initially chest wall deformity was evaluated by CT scan routinely for early onset scoliosis. It's moved away from that. But what we do learn is that when you do get a CT scan of the spine, make sure you get one of also it includes the ribs, because you can better tell if there's any rib abnormalities that may serve as a tether as well. MRI is important. It needs to be done in all patients. Again, you're looking for spinal dysraphism, some of which may require neurosurgical intervention. I already talked to you about the increased risk associated with surgery. In terms of timing, I don't get it immediately, because I do want to delay it in the very young to minimize the risk of anesthesia. But if I see a curve rapidly progressing, or if they do have an abnormal neurologic exam, I'll get it. I talked about the renal ultrasound. So let's talk about management. So observation is really critical for congenital scoliosis. Irrespective of how severe the deformity is, you need to get documentation that it's progressing. And so a severe deformity doesn't necessarily always need surgery. And so if it does progress, though, then you need to at least continue to observe it until growth is complete. Bracing, it's not effective for the congenital curve, but can help with controlling the compensatory curve. As for operative management, there's really kind of two categories, and that's the prevention of deformity. It's easier to prevent deformity than to correct it. And then there's obviously correction, which can happen acute versus gradual. In terms of prevention, it typically is usually in Situ Fusion. Historically, that was just done without instrumentation. This has now become more of an instrumented kind of correction in Situ Fusion. But ideally, what you do is you're stabilizing a small curve so that it doesn't otherwise progress. And you do it in really young patients. And it's unfortunately a little bit difficult to know exactly the ideal time to do it, because you want to document progression to know whether it's necessary. And you don't want to let a curve get out of control before you make this decision. Hemiepiphysiodesis, this is something that probably most of us don't really do anymore. It's the idea of correcting through growth by fusing the convex side and allowing the concave side to still grow. And the real reason is that we have better operations for it, especially if the ideal candidate's a hemivertebra. And because the growth on the concave side is not necessarily as reliable. Fusion and instrumentation, this is really for mixed deformities, and it's more skeletally mature patient. It does typically result in a long fusion, especially if you're managing both the congenital curve and the compensatory curve, and really is there for mixed anomalies. Hemivertebra excision is really an acute correction, removing the hemivertebra. It is really probably one of my most favorite operations to do. As I suggested before, I like to think of them as an extra half a vertebra, so removing it's not critical. It typically, you get a very big correction. Usually the average curve correction is in the mid-30s. Your goal is to make the discs above and below parallel. Typically requires some compression on the convexity and a little bit of distraction on the concavity, but it typically results in a short fusion. Ideal candidate is between the ages of 3 and 5. Osteotomy VCR, again, these are for the, this is where you'd like to stay away from. For severe rigid curves, typically with mixed anomalies. There's no available disc essentially to allow an instrumented correcting fusion to occur. You usually need acute both coronal and sagittal deformity correction. The advantage of obviously a VCR is that it shortens the spinal column, which theoretically decreases the risk to the spinal cord. but obviously is technically demanding from both the bleeding and neurologic. And then finally, fusionless surgery, the use of growing rods and vectors that allow for continued growth of the spine. It's really, if you have a patient with no good options, such as a patient that's less than 5 with multi-level anomalies, you're distracting the spine and really correcting the deformity through the open discs. It isn't very reliable, and when we look at growing rods and vector, typically it's the group that has the least benefit from fusionless surgery, but typically is done in a patient population where we don't really have a lot of other options. So in summary, for congenital scoliosis, failure formation, failure segmentation, this is the progression of deformity, block, veg, and so forth. And then really in terms of balancing the procedure, it's deformity correction versus complications. We have a little bit more time, so I just want to talk about a couple more congenital deformities. Klippel-Feil Syndrome, which is basically congenital fusion of the cervical vertebra. It's typically a failure of segmentation. So for whatever reason, we don't typically find failures of formation here. But there are associated findings similar to congenital scoliosis. The clinical findings of a Klippel-Feil syndrome are usually a short neck, low posterior hairline, and limited neck motion. But less than half the patients actually have all three. And it really is based on the number of fused vertebrae. So the more severe, the more number of fused vertebrae, the greater the clinical findings. Interesting enough, is probably the most common reason to have patients actually present besides just the clinical deformity is pain. And the pain doesn't come from the congenital portion, it comes from the unfused segments because of degenerative changes. And these degenerative changes even can present later in adulthood for patients that didn't even know they had congenital deformities or congenital anomalies in the neck, because now they're having radiculopathy or other neurologic findings. And it's really, important to better understand this, because as you see that MRI, it's these mobile segments that become hypermobile, ultimately degenerate, and then can lead to neurologic concerns secondary to instability. And then finally, just want to talk a little bit about congenital kyphosis. This is probably, thankfully, a much rarer case of a congenital anomaly, but probably one of the more concerning ones for us because of its high risk of neurologic injury. And so essentially, McMaster as well had a similar classification system that was based on failure formation and failure segmentation. But the natural history is it really kind of depends on, so type 1 is a failure formation and type 2 is a failure segmentation. Segmentation problems are usually less progressive. But if you have a failure formation, you're typically missing the vertebral body in the front, which makes it hyperkyphotic. And then if you have continued growth there, you get a deformity that can stretch the neural elements, which then risk neurologic injury. So I think that's about it. So any questions?
That was phenomenal. Thank you.
Yeah, awesome.
Burt, you guys have any questions for Burt?
Hey, Burt, do you see anything changing in the years to come for this group? I mean, they're for sure the ones we have the biggest issue with, right? Just clinically. Do you see like any of these other like fusionless gadgets that are out there that'll be more helpful? Or you think this is going to perpetually plague us as a specialty?
I think it's going to perpetually plague us as a specialty. It's interesting is, so what Seattle is developing is they are developing their in utero surgery. So they've hired very aggressively surgeons and medical physicians and they're working with Seattle Children's and University of Washington are working together. And so they're obviously already, this has been done for Milo, for intrauterine closures and so forth. It'd be really interesting to see if there's going to be some opportunity, in utero surgeries, if we can make these diagnoses and really the severe ones to kind of manipulate that. I mean, I think it's funny. I just heard a presentation on it, and that's where my mind went to as a spine surgeon. How could I change the outcome of some of these patients? It'd be really interesting if we could start doing it at that time for a couple of reasons. One is even with the myeloid closures, right? They've been shown that they can improve their neurologic function. So even if it's a risky surgery in a in a fetus, there's probably some potential for that to repair itself. Or maybe if you see a severe deformity, take something that's segmented and fuse it. Whatever the case may be, that's where I think potentially the future for this is ultimately going to be. It's not right around the corner, but my guess is that's where this may go.
Oh. I never thought about doing in utero work for a congenital deformity, but yeah, it'd be kind of interesting. Sweet. Any other questions, guys? Or so we're right at 7 o'clock. You nailed it, Burt.
Thanks. I don't know if I should have left more time for questions. So sorry if I needed.
Perfect. That's perfect. Thanks, man. Appreciate it.
All right, of course.
Yeah.